Hi there, my name is Alana Gould and I'm a specialist endocrine nurse completing a postgraduate diploma in endocrinology through the University of South Wales in the UK. I currently work in the Endocrine Diabetes and Research Centre at Wellington Hospital in New Zealand. In this short video clip I'm going to discuss fine needle aspiration or FNA of the thyroid. So some basic FNA facts. An FNA biopsy of the thyroid gland is an effective method to determine whether or not a thyroid nodule is cancer. The chance that a thyroid nodule is malignant varies with age, gender, radiation exposure and some other factors. The procedure is relatively simple and it's performed in a clinic or office and usually takes less than 20 minutes. Complications are rare but include bleeding, bruising and infection. Results are generally available within the week and help determine what further interventions or treatments are needed. So what are thyroid nodules? The thyroid gland is found in the neck just below the Adam's apple. The gland is responsible for producing thyroid hormones T4 and T3. These are important hormones that stimulate the metabolism of the body. Often the thyroid gland develops nodules, and thyroid nodules are so common that up to half of all people will have one, without any symptoms or effect. Like many things, the thyroid gland gets lumpier as we get older and the frequency of these nodules increases with age. Many are found incidentally during routine examinations or imaging. Thyroid nodules are more common in women than they are in men. Regardless of where in the body a new growth is discovered, as health professionals we always have some concern. This concern is around whether or not the nodule or growth is cancer. Fortunately, fewer than 10% of thyroid nodules are malignant. The majority of thyroid nodules are harmless and these are called adenomas. They are contained within a capsule in the thyroid gland. Even though malignant nodules are uncommon, we make further investigation to ascertain whether or not it is cancerous. A solitary nodule greater than 1 centimetre in diameter should undergo an FNA biopsy. There are a number of factors that increase our level of suspicion that the thyroid nodule may be malignant. So age is one. Patients less than 30 years of age and those older than 60 have higher risk of cancer in a thyroid nodule, as do children. If the development of the nodule has coincided with the onset of associated symptoms such as difficulty swallowing or hoarseness of the voice, we'd be more suspicious. If a patient has a past history of head or neck radiation, or if the nodule feels hard or fixed on palpation, or if the surrounding lymph nodes are large, we are also more concerned. Also, if the patient has a history of thyroid cancer within the family, we would be concerned. Nodules are of less concern if the patient has many nodules present within the gland. This is also called a multinodular goiter. And if a nodule is hyperfunctioning or hot on nuclear imaging of the thyroid, and this is called a toxic nodule. We will often order thyroid function blood tests and imaging scans to determine the functional activity of the thyroid nodule and review the overall thyroid anatomy. However, the cornerstone in the assessment of a solitary nodule is the FNA procedure. This biopsy to obtain tissue for analysis is the best technique for detecting or ruling out the presence of cancer. The procedure is technically quite simple and when performed properly, the testing has a false negative rate of less than 5%. So how is the FNA biopsy performed? Preferably ultrasound can be used to help guide the biopsy. This is especially important in cases where the nodule cannot be felt without difficulty or if the nodule has areas within it seen on previous imaging that are suspicious and specifically should be biopsied. Features on imaging that are suspicious and may increase the probability that a nodule is malignant include microcalcifications, irregular margins, hypoechogenicity, prominent internal vascularity, absent halo, or a nodule that is taller rather than wide, and any cervical lymph node adenopathy. Little preparation by the patient is required. There is no need to fast or to withhold medications of the day of the biopsy. An exception to this is occasionally a patient may be asked not to take blood thinning medication on the day of the biopsy. Informed written consent is obtained from the patient and any questions are answered at this point. After an examination to pinpoint the nodule, the patient is placed in supine position and the neck is slightly hyperextended. The doctor cleans the area around the neck. Our unit, this is done with a chlorhexidine swab. Sometimes doctors may choose to inject a local anaesthetic. Since the needle used for an FNA biopsy is so fine, anaesthesia often results in simply another uncomfortable poke in the neck. However, most patients undergo FNA biopsy managed without the use of anaesthesia very well. The ultrasound transducer is placed directly over the thyroid before aspiration to localise the nodule. Doppler imaging mode is used to identify and avoid large blood vessels in and around the nodule during the FNA biopsy. The patient is instructed not to swallow or speak during the procedure. Once the patient is ready, a small, fine gauge needle is inserted into the nodule. The needle is smaller in diameter than the needle used in most blood sample. We use a 25 gauge here. The needle is then passed through the nodule gently 3 to 4 times, but no more than 6, to obtain as much tissue as possible. This ensures an adequate amount of tissue is collected for cytological analysis. Once the needle is withdrawn, pressure is applied over the thyroid for 5 to 10 minutes. This is to minimise bleeding and also reduce any swelling. In our unit, the tissue is obtained from the FNA. It's then put into a specimen containing thin prep cytology mixture. This is how our pathology department has asked for this to be prepared, and this technique is said to yield greater cellularity and better nuclear detail than conventional smear techniques. However, my understanding is that in many other areas, the sample of thyroid nodule cells is prepared by smears onto glass slides and then sent to the pathologist for evaluation. First, the pathologist determines whether or not enough thyroid tissue has been obtained for analysis, and when there is an insufficient amount, a repeat biopsy is necessary. After analysis, the tissue is classified by the pathologist and typically reported within the week. Although the classifications used by pathologists vary, there's been a recent movement to standardise reporting worldwide, and tissue cytology is usually reported as benign, malignant, suspicious, or indeterminate. So indeterminate or non-diagnostic indicates that there are insufficient number of thyroid cells in the aspirate and no diagnosis is possible. A non-diagnostic aspirate should be repeated, as a diagnostic aspirate will be obtained approximately 50% of the time when this aspirate is repeated. Overall, 5 to 10% of biopsies are non-diagnostic. Benign thyroid aspirations are the most common, as we would suspect, since most nodules are benign. And these consist of benign follicular epithelium with a variable amount of thyroid hormone protein or colloid. Suspicious cytology makes up approximately 10% of all FNAs. The thyroid cells on these aspirates are neither clearly benign nor malignant. 25% of suspicious lesions are found to be malignant when these patients undergo thyroid surgery. These are usually follicular or Hürthle cell cancers. Therefore, surgery is recommended for the treatment of thyroid nodules from which a suspicious aspirate has been obtained. So, malignant thyroid aspirations can diagnose the following thyroid cancer types: papillary, follicular variant of papillary, medullary, anaplastic, thyroid lymphoma, and metastases to the thyroid. Follicular carcinoma and Hürthle cell carcinoma cannot be diagnosed by FNA biopsy. This is a very important point, since benign follicular adenomas cannot be differentiated from follicular cancer, about 12% of all thyroid cancers. These patients often end up needing a formal surgical biopsy, typically a hemithyroidectomy in the lobe that harbours the nodules. So some summary points about the FNA of the thyroid. Thyroid nodules are very common. Nodules greater than 1 centimetre should undergo FNA biopsy to exclude a malignancy. FNA is a safe and simple procedure that is commonly performed, and results of the FNA need to be taken in context of the overall clinical picture and determine what and if any follow-up treatment it requires.
and that's something that's driving me in misery. Oh, I can tell the way things change, that you've been loving some other man. That's why something keeps on worrying me. Yes, it is. That's why something worrying me. Oh, I can tell by the look in your eye. I can tell by the way you smile. I know things haven't been this way. I try to love you each and every day, and that's something keeps on worrying me. Yeah, that's why something keeps driving me in misery. Yeah. I can tell by the look in your eye that you've been loving some other guy. That's why something keeps on worrying me. Oh, yes, it is. That's why something keeps on worrying me. Oh, that's something, baby, it's deep down in my heart. It's worrying me, baby. I know you love somebody. I know you have somebody here. It's worrying me, baby. I need you right here by